Good morning to the assessor. I am Gilbert, a representative group head leader, and today we will present our case study of smear negative extrapulmonary tuberculosis that involves pericardial and pleural effusion. So this is the group members. We have Wardatila, we have Michelle, and we have Serene. In this slide presentation, our group has found a quite interesting case study, which the medical diagnosis is likely smear negative extrapulmonary TB that involves pericardial and pleural. It is interesting to all my group mates because the case had only presented in the ward just for 2 days prior to the admission. Let us grind it deeper in this presentation. Now, our case presentation starts with the biographical data of the patient. This patient is 37-year-old female, Iban Christian, and she has been working as a cashier at the supermarket for a few years. She has been married with having 4 children and lives in Miri. She also an ex-smoker which she smoked for 1 year and has been quitted 2 years ago. The current weight is 82 kg. And what are the chief complaints? Well, she had a progressive abdominal distension, roughly about 1 month. She also had experienced shortness of breath for 2 days prior to admission. And she also has a reduced effort tolerance, orthopnea, and proximal nocturnal dyspnea for 1 month. And now the medical diagnosis has been stated early in this presentation slide. Now I have broken down it into 4 functional keywords to make it easier to understand. Now the first one is a smear negative. That talks about an absolute negative result of or the absence of medical issue in the patient's body via a rapid initial test called acid-fast bacilli AFB. The second one is extrapulmonary tuberculosis, which means TB affects other organs than the lungs. Third is pericardial. So in this case, the pericardial that is affecting the pericardium, a condition called tuberculosis pericarditis, where it builds up fluid that turns into pericardial effusion. Lastly is pleural. In this case, it happens in the pleura that leads to tuberculosis pleurisy or pleural effusion. Here are the presenting symptoms. First, we have dyspnea on exertion, orthopnea, and paroxysmal nocturnal dyspnea (PND). The patient had been complaining shortness of breath, sometimes at night, and needed some time to continue walking after standing just to catch a relief. Second is an abdominal distension, where the patient complained about discomfort on abdominal. Third is bilateral leg swelling and obvious edema on both left and right leg.
Okay, next I will explain about the past health history. This patient has a background of underlying hypertension and was diagnosed with smear-negative extrapulmonary tuberculosis, for which anti-TB therapy Accurate 4 was initiated on 13 November 2025. She has requiring history of pericardial effusion with significant episode requiring admission in late September. On 9 November, a Plex view echocardiogram confirmed a left pleural effusion. To manage her condition, she underwent pericardiocentesis on 30 October to drain her hemoserous fluid from the pericardial sac. On 10 November, she had pleural tapping and biopsy, which revealed scanty benign tissue with no evidence of malignancy or granuloma. A planned pleuroscopy was postponed after follow-up ultrasound showed that the effusion had resolved. After that, she was started on guideline-directed medical therapy (GDMT) for heart failure, including perindopril, dapagliflozin, spironolactone, and bisoprolol. For TB, she received Accurate 4 and pyridoxine as a neuroprotective supplement. After starting anti-TB medication, she developed skin itchiness and rash on her lower limb. This was reported as a drug-related reaction and her treatment was monitored closely. Florence underwent several diagnostic assessments to evaluate the cause and extent of a pericardial and pleural involvement. Imaging studies were performed first. Serial echocardiograms were used to monitor the size and progressions of the pericardial effusion. And then checks X-ray revealed cardiomegaly, and this was further confirmed by CECT thorax, which demonstrated cardiomegaly, pericardial effusion, and reactive mediastinal lymph nodes. Fluid analysis was then carried out to further investigate the cause of the effusion. Pericardiocentesis yielded hemoserous fluid. However, AFB bacilli were not seen on smear, and TB culture was still pending at the time of assessment. Similarly, pleural tapping obtained hemoserous fluid with negative AFB, while both TB culture and TB PCR results were pending. A pleural biopsy was also performed, which showed scanty benign tissue with no evidence of granuloma or malignancy. Although microbiological confirmation was not obtained, the combination of imaging findings, fluid characteristic, and clinical presentation support a diagnosis of seronegative extrapulmonary tuberculosis. The laboratory and the microbiological investigation were also performed. So first, the blood test and the coagulation profile shows all the components were within the normal range. The renal profile shows urea level and creatinine level were slightly high. The liver function test shows the albumin level was slightly low and total protein was high. And the sputum, the genes expert was not detected. Okay, now for the body assessment, I will focus on the cardiovascular system and the respiratory system. So for the cardiovascular system, palpation revealed no trills or hives, PT edema was absent on examination, auscultation was performed over the aortic pulmonic, ERBs point, tricuspid, and mitral areas, and normal heart sounds were heard, no murmurs, wheezing, or bronchi were detected. For the respiratory system, assessment of the cricosternal distance shows no abnormalities. Bilateral chest expansion was equal and synchronized. Percussion over the anterior chest revealed resonant sounds bilaterally. Auscultation of both anterior and posterior lung fields demonstrate normal brief sound with no added sounds detected. Okay, now let's move on to the disease process. First, I will explain about the pathophysiology of TB spread. So, TB is a chronic infectious disease caused by the Mycobacterium tuberculosis, which primarily affects the lung but may spread to the extrapulmonary sites through lymphatic or hematogenous dissemination. In extrapulmonary tuberculosis, the host cells mediated immune response play a central role in disease development, resulting in granulomatous inflammation, cases necrosis, and accumulation of exudative fluid in affected tissues. In this patient, TB has involved both the pericardium and pleura due to the rich vascular and lymphatic supply, making them susceptible to mycobacterial spread. Now I will explain about normal anatomy and physiology of pericardium and pleura. The pericardium is a fibroelastic sac that surrounds the heart and functions to provide lubrication, limit acute cardiac dilation, and maintain normal cardiac, while the pleura is a thin double-layered membrane covering the lungs and chest wall that maintains negative intrathoracic pressure and allowing efficient lung expansion during respiration. Pericardial TB occur when Mycobacterium tuberculosis infect the pericardium. So this infection triggers a granulomatous inflammatory response within the pericardial layer. As inflammation progresses, capillary permeability increase, leading to the accumulation of an exudative pericardial effusion. So the fluid is typically protein-rich with high LDH. The adenosine may be mildly raised, which is suggestive of a tuberculosis cause. When the volume of pericardial fluid becomes large, it increases pressure within the pericardial sac and restricts the normal cardiac filling during the diastole. This results in reduction in stroke volume and cardiac output. So clinically, the patient may develop symptoms such as dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and bilateral lower limb swelling due to impaired cardiac function. So if the patient continues to accumulate rapidly or reach a critical volume, it can lead to cardiac tamponade. In this condition, the heart is unable to fill effectively, and echocardiography may show right ventricular collapse as seen in the patient. For the pleural TB, it occurs when Mycobacterium tuberculosis spread to the pleura, usually from nearby subpleural lung focus or through the lymphatic spread. Unlike pulmonary TB, pleural TB is mainly caused by a delayed type 4 hypersensitivity reaction to mycobacterial antigen rather than active bacterial multiplication. This immune response increases capillary permeability and disrupts normal lymphatic drainage. As a result, an exudative pleural effusion develops. The pleural fluid is typically protein-rich, has elevated LDH, and may appear humosurous. However, the bacillary load is often low, which explains why acid-fast bacilli are frequently not detected in pleural fluid. The accumulation of pleural fluid restricts lung expansion, leading to reduced ventilation. Clinically, this patient has a shortness of breath and reduced exercise tolerance. Because of pleural TB is immune-mediated, cytology results are often non-diagnostic, and pleural biopsy may appear benign if the tissue sample is insufficient acid in this patient. In Florence case, the clinical findings strongly support a diagnosis of extrapulmonary tuberculosis involving both the pericardium and pleura. Echocardiography showed a large circumferential pericardial effusion measuring more than 5 centimeters with evidence of right ventricular collapse indicating cardiac tamponade physiology. The pericardial fluid was hemoserous with an ADL level of 30.1 and no malignant cell were detected. Pleural fluid analysis also demonstrated a hemoserous effusion with high protein level of 50 grams per liter and elevated LDH at 790 units per liter, while glucose was preserved. Acid-fast bacilli were not seen, and pleural biopsy results were benign but not representative, which is consistent with smear-negative pleural tuberculosis. So clinically, Florence presented with progressive abdominal distension, dyspnea, autopnea, PND, and bilateral lower limb swelling, correlating with impaired cardiac and respiratory function. Based on this finding, she was diagnosed with lipemia-negative extrapulmonary tuberculosis involving the pericardium and pleura. Management was initiated with anti-tuberculosis therapy, including Accurate-4 and pyridoxine, alongside optimization of GDMT for heart failure.
Next, we'll look at the management and outcome for this patient. So let us look at the first medication taken by the patient, which is tablet Accurate-4, which patient needs to take 5 tablets once a day. This is an anti-TB medication with a combination of isoniazid, rifampicin, pyrazinamide, and ethambutol. This is a treatment of both pulmonary and extrapulmonary tuberculosis. Since it is a combination of 4 types of medication, so each of them brings their side effect, such as ethambutol will cause abdominal distress, pyrazinamide will cause peptic ulcer or diarrhea or vomiting, and rifampicin will have side effect of rash, pruritus, or hematuria, and isoniazid will have a side effect of peripheral neuropathy. So to overcome this side effect, the doctor will add on such as pyridoxine, 20 mg once a day, which is a prophylaxis to the peripheral neuritis in isoniazid therapy. And tablet loratadine 10 mg OD is an antihistamine, which is prescribed to the patient to reduce a rash and pruritus. So the outcome for this Accurate-4 medication shows a clinical improving with echo showing decreasing pericardial effusion from 0.63 to 0.2 centimeter, which is more than 50% reduction. And the other medication is dapagliflozin 10 mg to be taken once a day. It helps to reduce the risk of cardiovascular events, which have the outcome of mild diuresis, improve cardiac metabolism, and reduce cardiovascular mortality. Continue with tablet spironolactone 25 mg once a day is a potassium-sparing diuretic used to reduce the edema in patients with chronic heart failure. So we can see that in the ultrasound thorax dated 27 November, there is no more pleural effusion. Move on to tablet perindopril 8 mg once a day and tablet bisoprolol 2.5 mg once a day. Both of these medications are antihypertensive, however, are used in patients with congestive heart failure. Perindopril is a SCE inhibitor used to reduce the blood pressure. It can reduce vasoconstriction. So here we can see that the blood pressure of patients during her hospitalization ranging systolic 107 to 149 mmHg, diastolic ranging 67 to 99 mmHg. While tablet bisoprolol is a beta blocker used to slow down the heart rate and improve the ejection fraction, hence reduce the arrhythmias. So we can see that patients able to ambulate, no complaint of autopnea. So the combination of 4 medications, namely perindopril, spironolactone, bisoprolol, and dapagliflozin, reduce the fluid in patients, lowers down the blood pressures, adds a diuretic and metabolic support, hence protects the heart from overwork and arrhythmias. And remember, just now I mentioned about the side effect for ethambutol and pyrazinamide. Both that medication can cause abdominal distress and peptic ulcer disease. Hence, here we can see that the doctor prescribed patients with tablet pantoprazole 40 mg once a day as a prophylaxis for the abdominal distress and the peptic ulcer disease. Now we will look at the procedure plan for patient, which is pleuroscopy. Pleuroscopy is an invasive diagnostic procedure to accurately diagnose a patient between TB pleurisy and non-TB pleurisy. Patient undergo this procedure would be given local anesthesia for the entrance of pleuroscope to obtain the pleural fluid sample, according to Lee et al. 2021. So our role before the procedure is to make sure consent is taken from the patient for the pleuroscopy. And next, patient to keep nearby mouth 6 hours before the procedure. And patient to stop NSAIDs and anticoagulant 7 days before the procedure. Blood such as Bill's blood count and PT-PDT needs to be taken. and advise patient to shower with antiseptic solution the night before procedure. Hence, while patient keep meal by mouth, we need to ensure patient electrolyte balance with intravenous strip of 1.5 liter normal saline per day and 4 hours monitoring of blood sugar level to avoid patient having hypoglycemia. However, on 28th of November, pleuroscopy was cancelled due to no pleural effusion after done ultrasound scan. So the absence of pleural fluid in the pleural cavity will increase the risk of punctured lung if we continue with the procedure pleuroscopy.
Let's move on to nursing care plan. First nursing diagnosis is impaired gas exchange related to accumulation of pleural fluid due to tuberculosis as evidenced by dyspnea, octonia, decreased oxygen saturation, and chest discomfort. So the goal is patient will maintain oxygen saturation within normal range, which is more than 95% during hospitalization. These are the nursing interventions and rationales. The first one, nurses should assess respiratory status such as respiratory rate, depth, oxygen saturation, and auscultate the lungs. This is to detect early signs of respiratory compromise. The second one, position patient in semi-bolus or bolus position. This is to promote lung expansion and reduce work of breathing. The third one, monitor oxygen saturation continuously or as ordered and not any decrease in indication. This is to evaluate the adequacy of oxygenation. For the fourth one, auscultate the lungs for crackles and abnormal breathing sounds. This is to identify any fluid accumulation in the lungs. The fifth one, administer oxygen therapy with the correct type of oxygen therapy and oxygen level as prescribed and monitor the oxygen saturation after that. This is to increase oxygen availability to the body tissues. The last one, encourage deep breathing and coughing exercises and ask patient to demonstrate it back. This is to help removing secretions and encourage better gas exchange. The second nursing diagnosis is excessive fluid volume related to impaired venous return and cardiac filling secondary to pericarditis as evidenced by progressive abdominal distension or ascites, bilateral lower limb edema, dyspnea, and orthonia. The goal is patient will demonstrate reduced peripheral edema and abdominal distension within hospitalization. The first nursing intervention is to assess edema such as its pitting, taking notes of the depth, location, duration of rebound, and progression, and document it daily. This is to evaluate whether fluid overload is progressing or responding to treatment. The second one is to monitor the daily body weight every morning by using the same body scale and make comparison to the previous readings. This is to detect indication of fluid overload and progression. The third one, elevate lower extremities with the edema while resting on bed by putting pillows or folded blankets under the affected leg and encourage leg elevation when sitting. This is to promote venous return and reduces the edema. For the third one, position patient in semi-bolus position. This is to reduces venous return and respiratory workload. The fifth one, administer medications such as diuretics as prescribed by the doctor at the right time, while also monitoring the urine output, blood pressure, and electrolytes. This is to promote removal of the excessive fluid. And the last one, educate patient regarding on the fluid and sodium restriction if ordered by explaining to the patient why limiting salt and fluids is important using simple words and examples. This is to prevent further fluid retention. The third nursing diagnosis is decreased cardiac output related to ineffective ventricular filling secondary to pericardial effusions, such as evidenced by dyspnea, optonia, paroxysmal nocturnal dyspnea, abdominal distension, bilateral lower limb edema, and fatigue. The goal is the patient will demonstrate adequate cardiac output as evidenced by blood pressure and pulse rate, and also the rhythm within normal parameters for the client, and the ability to tolerate activity without symptoms of dyspnea or chest pain. The first intervention is to monitor vital signs such as the blood pressure, heart rate, respiratory rate, oxygen saturation, temperature, and also the pain score trends frequently or hourly, and take note for abnormal readings. This is to detect early recognition and allow quick intervention before deterioration occurs. Second one, assess the jugular venous distension by assessing the patient's neck veins and observe for jugular venous distension. This is because jugular venous distension indicates increased central venous pressure due to impaired ventricular filling. The third one, position patient in a semi-flawless position and adjust positioning based on patient's comfort and respiratory status. This is to decrease cardiac workload and improve cardiac efficiency. For the third one, auscultate heart sounds, take note muffled heart sounds, abnormal rhythms, and monitor for changes. This is to detect accumulation of pericardial fluid that further restricts cardiac filling. The fifth one, monitor intake and output daily, weight, especially after administering diuretics. This is to monitor the effectiveness while preventing hypotension or electrolyte imbalance. The last one, prepare patient for investigation procedures such as echocardiography as prescribed by the doctor and explaining purpose of treatment to the patient. So, echocardiography confirms the presence and the severity of pericardial effusion or constriction. So, nursing support ensures patient safety and also for early detection of complications.